right? So it's all part of the same process. Like you're doing everything that you're doing on that rubric is it's a continuum essentially, right? So it's about tissue handling, right? So you're using a tooth forceps rather than a non-tooth forceps because then you don't get crush effect. And what you're doing here is you are lifting the skin and everting it, and then you are going straight through 90 degrees, coming through, and then lifting up the other side in the same way, only now you're everting it the other direction. You're trying to align the two exit points. So you have the entry here and then the exit here. So you have to sort out where that is, and then you're trying to space them far enough away from each other so that this is generally even on either side. A few millimeters one way or the other doesn't make a difference. And then when we're instrument tying with Prolene, you have to do something called the surgeon's knot. So it's 2 throws, and then you're laying this down square like so. Now, the problem with Prolene is it then releases and you lose the tension on it. So what I do is then when I've got the right tension, I slip this over like that to lock it down. And now I've got that residual tension in the suture. And even then, it's a little bit, you want to be able to get a little bit underneath I use this actually as my guide, is I want to slip the needle driver underneath, otherwise you have too much tension on it. You don't want this ridiculously tight, because if you do, what will happen is the skin will necrose. So having the suture too close to the skin edge and having it too tight will result in you having a suture that is too tight, and you'll actually have some necrosis of the skin. Now, this being the case, there's actually no intrinsic retraction that's happening because of the material that we're trying to sew, and this is too loose. This is actually much too loose. It's very difficult to get it to be very similar to a human, because living tissue has a tendency to act differently than this hunk of meat, you know? So there's an intrinsic retraction that happens because of the tissue itself. But that would not be considered a good suture in a human, because that would wind up gaping. Here it looks really good, but that's way too much, that's way too loose. So I would not consider that to be a good suture. It's challenging to do this on a pork hock or anything like that, because you are you're not dealing with a living tissue that will then react the same way as when you're doing this in a human. So you have to take it with a grain of salt. So now I'm going to wind up doing this much tighter this time, because I know that it's going to slip. And as a result, what happens is the edges of this now do not evert, because I've had to tighten it so much that now they're not everting. So the part of this is the substrate you're working on makes this challenging to really be the same as in a human. And so when I'm doing it like so, now I have to go back and adjust and evert the skin, so now the suture holds it the way I want it to. You don't have to do that in a human usually. And then we just have to put another one next to it in order for, you can see how it's inverting on the edges here, because I've everted it here, and now I just have to carry on doing the next bite. And again, you're trying to do this at the same distance away from the skin edge each time. But you see now how it's overlapping, and that's simply the nature of the substrate that we're working on. It's not like this in human. This is, again, it's overlapped. You see, like that, and that's really hard to avoid in a simple suture. And I can show you how we deal with that otherwise, because there are sutures that are meant to actually assist this eversion of the skin edge. This is quite challenging, actually. So the other way that we do this is with a vertical mattress suture. So a vertical mattress suture, you're going perhaps 8 to 10 millimeters away from the edge. Again, the same eversion with your forceps hand. So you're going away from it again about 10 millimeters away. And then what you do is you flip this needle around so it's pointing the other direction. And you then take only 1 or 2 millimeters on the same line backwards, like this. Okay, and then when we tie that down, now you can see that it forces the eversion, right? Of course, you get these other strands from the last one in your knot. And you can notice that what I'm doing when I'm tying this is that my suture, I'm going this direction with my sutures, and then I come back the other direction. So that's what we call a square knot. So that's part of the knotting rubric. You can see how different the two are because of that, right? Because again, now I can get this everted, but you can't really do it well on this slab of meat with a simple suture. Now that I've got this one working, I can then manipulate this tissue so that it is everted under those simple sutures. But you really need a vertical mattress to help maintain that positioning, because these by themselves, they just lay flat. And so the tendency is for this cold pig skin to invert, and it's really hard to make it otherwise. Human tissue will react much more differently. So it's a bit of the problem with the model, but that's how you could actually potentially set it up with a couple of these in place already from somebody else. Like you could do a couple of vertical mattress sutures on either end of this incision. Have this set up so it's pre-everted for them, and then you could have them do interrupted simple sutures between, and that would be a little bit better, give them a little fairer result of what their technical ability is. And then this is really a very, very efficient use of the suture. But you can see how I'm laying it flat, and then I just pull this over and lock it down so I don't lose that tension. And then my next throw, I'm throwing the other direction. You can see I'm bringing the suture towards me here, and then the next one away from me, towards me, away from me. And that's how you make sure that those are the square knots. But you can see now how nicely everted that is, right? So then if you were to go and take a and this is part of just trying to help you with the model, that then if I take this new suture and I'm just asked to do a simple suture in the middle of these two, now it's pre-everted. So I'm going to be able to then just demonstrate as I did before. So you're about 8 to 10 millimeters away from the skin edge. Same thing on this side on the same line. And now we're just doing a simple suture. So again, 3 or 2 throws. And again, it's going to wind up being, you have to be dynamic with this. You can't just lay stuff down. You actually have to get the tissue to go with the way you want it to. You can just leave that, flat like that if the tissue tension will allow you to. You can just leave that, and then, but the next thing has to be the other direction. So I threw that one towards me. Now I'm throwing the next one away from me, and then towards me, and away from me. And usually it's 4 to 6 with Proline. And then again, you have to go back and adjust it so that it stays. So that's part of the trick, is that people want to just leave put a suture down and it should just be the way you want it to, right? But the tissues don't always do exactly what you want them to. And so you actually need to, it's fair, I think, to be able to adjust the skin so that it actually sits the way you want it to. That's because that's the way we do it in the real world. And then the other rubric, of course, is, are my sutures holding? Like when you pull on them, do they come apart? Do the knots come apart? And they don't. Now I can stretch them like crazy. And so, the idea of, well, how tight are they? Well, I had to do that, test that before I stretched everything. But you should be able to get at least the forceps underneath between the skin and the suture, because that gives you the right that way you've got the right tension. So those are the bits. You can see that the rubric from the point of view of tissue handling, you're grasping, you're everting, you're using the tooth forceps as fine as possible. You're taking my bites away from the skin edge are quite even, and they're the same for each side. That's probably the biggest trick, is that you don't favor one side versus the other, right? You don't take a big bite on one side and a smaller bite on the other side. You're trying to keep those as even as possible. So that's, but this model is tough to just do purely simple sutures on, because the tissue doesn't act properly. Yeah.
And lastly, did you want to comment on the economy of motion? Essentially, like not moving too much, not.
Yeah, and I think it's really. I think you could see here that essentially, you are, you're just. I don't know. It becomes second nature, and so how do you put that into words? I'm not quite sure. But there would be people who would tell you, well, what you should do is just, drive the suture right across the entire wound. But again, rather than what I did this in 2 bites. I don't think it's wrong to do it in 2 bites, especially when you're trying to really place your sutures in a way that allow you to evert things. But there's definitely an economy out of just going right across the entire wound like that. But sometimes you don't get the same depth of bite on each side, and so you can have some unevenness. So when I don't have easy tissue to close, I do it in 2 bites. I don't think that that's lack of economy, because what you're gaining from that is better tissue apposition, and in the end, one that you don't have to cut out and do again because you kind of messed it up by trying to do it all at once, right? So, and also it depends on the size of the needle. This needle is an FS2. I mean, there's only a certain length that you can go through here, right? So, you know, if I try to get this through, you can see I'm pulling up on the skin, trying to actually push this through. And so what I have to do, I can't get the needle through this other side, and I have less control over where it's coming through. So now I have to ungrasp the needle, then regrasp it here to then try to get it out, you know, and then I'm pushing. I find that more traumatic for the skin and the tissue. I'm doing a lot of this wiggling and stuff. And so it depends entirely on what tissue substrate you're dealing with. Sometimes you can do that. You can lift this up, you can go through, and I do this, I might not re-grasp every time, like, you know, this is what we call taking it in two, because you're going one bite, resetting, going through again, or you're doing one bite and again grasping the other side to stabilize it and driving it through. But you can see even then I've got to actually reset my needle, and for a non-expert you'll lose the direction, and all of a sudden, you know, the needle's coming out over here because, you know, you had to re-grasp while it was in the tissue. And so you know, experts can actually maintain that angle, and sometimes we even can't maintain that angle. So, you know, and now you're pushing really hard here to just get this point through, and now you have to try and search for this needle. So I see, like, it's not economy. You know, you might think, well, just drive the whole thing through, but there's so much more to it than that, and then it compromises other parts of the rubric. So that's why I do it the way I do. I will take it like so. In this very thick-skinned model, I will do it like this. And that might not seem economical to some people, but it definitely is. And I'm assuming that you're going to want to do instrument ties, or do you want people to do hand ties? That's the other thing.
Do you want to demonstrate both really quickly?
So I've been doing instrument ties for all of these things. Most of the time, when you're doing skin and you're doing this, you're doing instrument ties. Almost always, simply because you use up so much more suture with a hand tie that you wind up going, these are only 18 inches long, and so you use so much more suture to try and close a long laceration. And that's why, so you talk about economy, well, suture economy is way less when you're trying to do a hand tie, because you just need to use, I'm using all of this to try and create the knot, whereas in an instrument tie, I'm only using this much, right? This segment from here to here, because I can do the tie like that. Do you understand what I'm saying?
Absolutely.
Yeah. So, I mean, I can do a single tie here. And again, you have to, with Proline, you have to get your finger right down to the bottom. And the other thing that you do in this case is you don't do that surgeon knot, but just to demonstrate again, you can see this would be considered a forehand part of the loop. If you're going the other direction, this is backhand. So you're, so at this point, I'm going to do a forehand. Okay, I'm going to get that down on the skin, and now I do another forehand because I need to be able to slide this knot to get the right tension. So I'm going to do another forehand, and then I'm going to leave the one in my right hand, my non-tying hand, vertical, so that then I can actually push this down and get the right tension. Okay, and then see how it comes off? See if I lift this up, look at how I lose that. I lose that tension. So you have to actually be very careful when you're doing your next throw, which has to be a backhand to lock it down, not to put any more tension on it, because you want it to stay like that amount of tension. And now you've locked it with that next backhand throw. Then you do forehand throw, then you do backhand flip throw, forehand throw, backhand throw. And every time that you do this, you need to get that finger right down on the knot so you're not getting an air knot. If you do this, the likelihood is you're going to break the suture and you're going to get what we call an air knot or a gap in the knot, and then that allows for laxity to develop later on. And again, we have to manipulate this tissue so it's everted. But that's pretty good at that point. Like, that looks really nice. And that tension is good. I can get that underneath. So, yeah, so the economy of movement is, I think, depends on what the model that you're working on it is. Because in this case here, for me to do it the way I'm comfortable, making sure that I've got the right depth and the right distance, I'm going to be doing them in 2 bites. But that's not always wrong. It might take you a little bit longer, so your rubric, winds up that ratio of, all of these points over time might be a little bit less. Like, your time is going to be a little longer, your denominator is a little longer, but you've got more points to divide them by, right? So you've got a better overall score, I would think. If you're doing those suturing techniques, taking your time doing it, and ultimately you don't have good tension, you don't have good eversion of the skin, you don't have any of the good things done, you've taken a lot of extra time to not do a good job, well, you're going to have a poor score, right?
Absolutely.
Yeah. So those are the things. I mean, you can see, I'm a little bit scattered here with I've got a little bit. I mean, I wasn't planning on doing it in this way, but I'm generally about 1 centimeter apart, and my sutures are evenly spaced on either side of the wound itself. So you want that for sure. This one is a little bit loose because look how much I can pull away. This one is also a little bit loose. Part of it is also once you start suturing things, your initial sutures sometimes wind up being looser because you have taken the tension off by putting more sutures in. And so your original tension that was required to bring things together is not the same as it was because the wound itself has changed. So, but when I get this properly everted, that one's pretty good. This one's still a little bit loose. This one's good. This one's good. This one's good. And this one's good. So that's how I would approach it.